Welcome to this deep dive.
Yeah.
If you look at how we treat a broken bone, there's this comforting binary precision to it.
Right, yeah. It's very straightforward.
Exactly. You look at an x-ray, you see that jagged white line, and the doctor points to it and says, there's the problem. You cast it, it heals, and, we move on.
And I think we naturally expect all of medicine to work that way, like visible, perfectly categorized, intentionally engineered.
We do. But today, we're looking at a stack of historical medical journals, pharmacology textbooks, and these massive psychiatric studies that prove just how messy medical progress actually is.
Oh, it is so messy.
We are wading into the accidental, controversial, and fundamentally misunderstood world of first-generation or typical antipsychotics.
Yeah, which is arguably one of the most significant yet scientifically muddy chapters in all of modern pharmacology. I mean, we're talking about medications that emptied psychiatric hospitals in the 1950s, basically entirely by accident.
Right. So we're going to explore that incredible origin story, the precise biological mechanisms like how these drugs actually physically block dopamine in your brain, the severe and sometimes permanent side effects, and the fierce debate still raging in emergency rooms today.
There's a lot to cover.
There is. Okay, let's unpack this.
Yes.
Because before we get into the heavy biochemistry of how these drugs alter your brain, we really have to look at how they were discovered. Because, if you were trying to cure severe psychosis in the mid-20th century, you weren't looking in a psychiatric lab, were you?
Not at all, no. If we jump back to 1949 and 1950, you actually have to look at a French naval surgery ward and a pharmaceutical chemist named Paul Charpentier.
Okay, a naval ward.
Yeah. And he synthesized a compound called chlorpromazine. But his objective had absolutely zero to do with mental illness. He was working with a class of chemicals called phenothiazines, and he was just trying to create a better allergy pill, like an antihistamine.
So wait, the foundation of modern psychiatric medication started with someone trying to cure the sniffles.
Yeah. I mean, that is the irony of it. But the compound made its way to a French surgeon named Henri Labouré, and Labouré wasn't interested in allergies. He was desperately looking for something to give his patients before surgery to prevent surgical shock.
Which was a massive killer at the time.
Huge. So he started administering chlorpromazine to patients and noticed it did something, well, highly unusual. It didn't just sedate them like a standard anesthetic.
Yeah, I was reading the translated notes from the historical journals we pulled, and Labouré described it as inducing an artificial hibernation.
Wow.
Which, sounds like something out of a science fiction novel. Yeah. It wasn't knocking them unconscious, right? It was creating this profound, detached indifference to their surroundings.
Indifference is the exact right word. They were awake, but they simply did not care that they were about to undergo major surgery.
That's wild.
It is, and Labouré was so struck by this that he aggressively pushed his colleagues across different medical fields to just test it. And that push eventually convinced two psychiatrists in Paris, Jean Delay and Pierre Dennecker, to try chlorpromazine on psychiatric patients in 1952.
Okay, we have to pause here and set the scene for what psychiatric care looked like in 1952, specifically for a patient with severe agitated schizophrenia, because the tools they had were pretty grim.
No, grim is putting it lightly.
Yeah.
The standard of care for severe unmanageable psychosis involved physical restraints, inducing comas with massive doses of insulin, or...
Well, lobotomies.
Exactly, performing prefrontal lobotomies.
Right.
That was the reality. So when Delay and Dennecker administered chlorpromazine to a 24-year-old patient known as Jacques L., who was severely delusional and violently agitated, they were really out of good options.
And the result was unprecedented. Within days of receiving these injections, this man wasn't just subdued. He was calm enough to walk in the hospital garden, play cards, and, engage in ordinary conversation. The psychosis was fading.
Yeah, it was a medical earthquake. Delay and Dennecker published their findings that very same year. But they needed a new word to describe what this drug was doing, because it wasn't just a standard sedative.
Right.
So they coined the term neuroleptic, which comes from Greek roots meaning roughly to seize the nerve.
Because the drug was seizing control of the nervous system.
Exactly. Patients were calm, but alert. Although the doctors did notice many patients developed these stiff, mask-like facial expressions and rigid movement.
Which is key for later.
Very key. But at the time, they actually thought those stiff movements were just a newly unmasked symptom of schizophrenia itself.
Wait, really?
Yeah, they didn't realize it was a side effect of the chemical they were injecting.
Oh, wow. That tragic misunderstanding about the side effects would obviously take years to unravel.
Yeah.
But the immediate societal impact was undeniable, right?
Yeah.
And chlorpromazine hits the U.S. market in 1954 under the brand name Thorazine.
Yes, Thorazine.
And it is widely credited as the catalyst for the mass deinstitutionalization of psychiatric patients. State hospital populations peaked right around 1955 and then went into this steep, decades-long decline, largely because patients could finally be managed chemically in the community.
Which was a massive shift in public health.
But there is a glaring historical quirk here regarding the name, because the pharmacology texts we're using today categorize Thorazine and its cousins as typical antipsychotics.
Right.
But nobody in the 1950s was calling them that.
Yeah.
It reminds me of how historians talk about World War I. You know, while soldiers were fighting in the trenches, they didn't call it the First World War. They called it the Great War. It only became the First World War after the second one broke out.
Right.
So typical antipsychotic is an entirely retrospective label, right?
That is a brilliant way to frame it. Yeah, the label typical has no inherent scientific or structural meaning. It only came into existence decades later when a second wave of drugs, starting with clozapine in the late 1980s, was developed.
Right.
The industry called the newer drugs atypicals to basically market them as different and superior. So consequently, the older drugs were slapped with the label typical, simply meaning the old stuff.
Wow.
Yeah. In fact, modern pharmacologists much prefer the terms first generation and second generation because the word typical implies a clean scientific category that, well, just doesn't exist.
So humanity accidentally stumbles onto a miracle drug that empties out the asylums and slaps a confusing retrospective label on it. But that begs the biggest question. How on earth does an allergy medicine stop someone from hallucinating?
Right. So the clinical success forced researchers into the lab to reverse engineer the drug. They needed to find the mechanism. And in the 1960s, a Swedish pharmacologist named Arvid Carlsson made a breakthrough that would eventually win him a Nobel Prize in the year 2000.
Okay.
He discovered that these neuroleptic drugs were doing one very specific thing in the brain. They were blocking the receptors for a neurotransmitter called dopamine, specifically the dopamine D2 receptor.
And researchers at the time were already suspicious of dopamine, weren't they? Because they were watching the effects of heavy amphetamine use in the general public.
Exactly.
And amphetamines flood the human brain with dopamine. And if you take enough of them, you can induce a temporary psychosis in a completely healthy person that looks, well, biologically identical to paranoid schizophrenia.
You combine those two observations and the puzzle pieces snap together perfectly. Flooding the brain with dopamine causes psychosis. Blocking the brain's dopamine receptors relieves psychosis.
Right.
This birthed the dopamine hypothesis of schizophrenia. And to this day, despite all our advancements, D2 receptor blockade remains the single best supported biological model for how we treat psychosis.
So because the drug can't distinguish between these four pathways, it's basically like using a sledgehammer when you really need a scalpel.
Well, this raises an important question. Because how do you ethically treat a patient when your only tool forces you to shut off the main breaker? This indiscriminate blocking is the defining first principle of the entire drug class. And to understand why that lack of a GPS system creates a nightmare of side effects, we have to map out what pharmacologists call the 4 dopamine pathways.
Right, because dopamine is not a one-trick pony.
Exactly. It does vastly different jobs depending on which neural highway it happens to be traveling on.
It's like walking up to a house where one light bulb in the attic is flickering and driving you crazy. But instead of just unscrewing that one bulb, you go down to the basement and shut off the main electrical breaker for the entire house.
I love that analogy.
You fix the flickering light in the attic, sure, but now the refrigerator stops running, the security system goes offline, and the plumbing freezes.
It perfectly illustrates the biological reality of first-generation antipsychotics. Let's look at the attic light bulb first.
Okay,
That is the mesolimbic pathway. When dopamine is hyperactive here, you get the positive symptoms of schizophrenia. The auditory hallucinations, the paranoia, the delusions.
So blocking dopamine here is exactly what we want the drug to do.
Exactly. So the drug successfully shuts off the flickering attic light. But what is the refrigerator that we accidentally turned off?
Right. What breaks?
The refrigerator is the mesocortical pathway. This neural highway manages motivation, emotional response, and cognitive function.
Oh, I see where this is going.
Yeah, in a patient with schizophrenia, this pathway is actually thought to be underactive already, causing what we call negative symptoms: flat affect, social withdrawal, lack of motivation.
So when the drug blocks dopamine there, it does nothing to help. and can actively worsen those negative symptoms.
Exactly. It's incredibly counterproductive.
What about the security system in our analogy? The third pathway.
That brings us to the nigrostriatal pathway. This is a major motor circuit in the basal ganglia of the brain. It has absolutely zero to do with psychosis or thinking. It is solely dedicated to smooth, coordinated physical movement.
Okay, movement.
Crucially, this is the exact same pathway that naturally degrades in a patient with Parkinson's disease.
Oh, wow.
So when your antipsychotic drug blocks dopamine here, it chemically mimics Parkinson's disease. You get tremors, muscle rigidity, and a shuffling gait.
Which explains why DeLay and Denneker saw their patients developing those stiff, mask-like faces back in 1952.
Precisely.
Okay, and the fourth pathway. The plumbing that freezes.
The tuberoinfundibular pathway. This one requires a quick look at how the brain regulates hormones. Normally, in a healthy brain, dopamine acts like a heavy foot on a brake pedal, constantly suppressing the release of a hormone called prolactin from the pituitary gland.
So when the drug blocks dopamine here,
It's lifting that foot completely off the clutch pedal. Prolactin production goes into overdrive,
and a massive spike in prolactin causes what exactly?
a condition called hyperprolactinemia. It leads to severe hormonal cascades, inappropriate lactation in both men and women, abnormal breast tissue growth, severe menstrual irregularities, and profound sexual dysfunction.
Wow. Which means the collateral damage, specifically in that third pathway, the motor control pathway, really becomes the defining feature of the patient's daily life.
It dictates everything, and it forces psychiatrists into a really brutal balancing act, which is best understood by looking at drug potency. Let's compare chlorpromazine, our original 1950s drug, with another foundational medication that came along a few years later, haloperidol.
Right. And looking at the pharmacology texts, haloperidol was another massive chemical accident. Synthesized in 1958 by a Belgian chemist named Paul Janssen. He was actually trying to modify a synthetic opioid painkiller, right?
Yeah, and he noticed the lab animals exhibiting the same behavioral calmness as they did with chlorpromazine. But the chemical structure was entirely different, completely different chemical class, but it achieved the exact same D2 dopamine blockade.
But haloperidol was much stronger.
Astronomically more potent. And we need to define potency carefully here because it relies on something called receptor binding affinity. Haloperidol physically binds to and sticks to the dopamine D2 receptor much, much tighter than chlorpromazine does.
So because it has a tighter grip, you don't need to flood the body with as much of the chemical to get the same antipsychotic effect.
Exactly. To halt a psychotic episode, a doctor might need to prescribe anywhere from 300 to 800 milligrams of chlorpromazine per day. With haloperidol, they only need 1 to 5 milligrams.
That's incredible.
It's almost a 100-fold drop in the physical amount of drug required. This is the basis for what clinicians still call chlorpromazine equivalence, a mathematical scale, to compare doses across these wildly different drugs.
But you know, if I'm a patient, I don't really care how many milligrams the pill is as long as it works. The issue is that the potency heavily dictates which terrible side effects you're going to suffer from. It's like a clinical soundboard with two terrible sliders. If you slide the sedation dial down, the movement disorder dial gets pushed dangerously high.
That soundboard analogy is exactly how emergency psychiatrists have to think. High-potency drugs, like haloperidol, are on one extreme of that soundboard. Because they bind so tightly to the dopamine receptor, they trigger massive violent disruptions in that nigrostriatal motor pathway. We call these extrapyramidal symptoms, or EPS.
And these aren't just mild twitches either. The medical literature describes acute dystonia, which can hit within hours of a single dose.
Yes, it's brutal.
It's a sudden, agonizingly painful muscle spasm, often in the neck or jaw, where the patient physically cannot straighten their head, or akathisia, an intense, torturous inner restlessness where the person feels like their skin is crawling and they just have to pace the room endlessly.
It is absolute agony for the patient. But if the doctor wants to avoid pushing that movement disorder slider so high, they have to use a low-potency drug like chlorpromazine, and then the other slider goes up.
Because you have to pump 800 milligrams of it into the body.
Right. To get the antipsychotic effect, the drug spills over and starts blocking other receptors. It was never meant to target like histamine and muscarinic receptors.
Which leads to massive knockout sedation, huge drops in blood pressure when the patient stands up, and what the texts call anticholinergic effects, which, in plain English, means the drug blocks acetylcholine, drying the entire body out.
Yeah.
The patient gets severe dry mouth, blindingly blurred vision, and chronic constipation.
The physician is permanently trapped between those two sliders. For decades, haloperidol became the default in emergency rooms worldwide, simply because doctors prioritize predictability. Haloperidol won't accidentally drop your blood pressure to dangerous levels or sedate you into a coma, but they were constantly fighting that movement disorder dial.
Yeah, and here's where it gets really interesting, because everything we just talked about, the spasms, the dry mouth film, those are the acute immediate reactions. But as patients stayed on these first-generation drugs for years, a much darker long-term consequence emerged. One that didn't just challenge medical science, but actually sparked a massive civil rights movement.
We are talking about tardive dyskinesia, commonly referred to as TD. Tardive meaning delayed, and dyskinesia meaning abnormal movement. This is a severe neurological disorder that typically only emerges after months or years of continuous exposure to these dopamine-blocking drugs.
The visual descriptions of TD in the source material are just heartbreaking. It manifests as involuntary, repetitive, almost rhythmic movements, severe facial grimacing, constant lip smacking, tongue protrusion, and sometimes writhing movements of the fingers and toes.
And the patient has absolutely no control over it.
None.
And the most devastating pharmacological reality of tardive dyskinesia is that it is frequently irreversible.
Even if you stop the drug.
Even if the psychiatrist completely tapers the patient off the antipsychotic drug, the repetitive movements often persist and in some cases permanently worsen. The brain's motor pathways essentially become structurally hypersensitive after years of dopamine blockade. Historically, the incidence rate of TD for patients on long-term typical antipsychotics was a staggering 20 to 30%.
It is one of the starkest, most tragic examples in modern medicine where the cure leaves a permanent scar that outlasts the disease itself. And because it was so visible you couldn't hide it, TD became a highly visible symbol of psychiatric damage.
Absolutely.
In the 1970s and 80s, patient advocacy groups organized around this. They demanded changes to the law, fundamentally reshaping the concept of informed consent. They argued successfully that you cannot chemically alter a patient's brain without exhaustively explaining the risk of permanent motor damage.
It revolutionized patient rights. And, TD wasn't the only terrifying risk on the consent form. There is also neuroleptic malignant syndrome, or NMS. This is rare, but it is a life-threatening medical emergency. It's triggered by a sudden, massive drop in central dopamine activity. A patient with NMS develops a dangerously high fever, severe lead pipe muscle rigidity, altered consciousness, and wildly unstable blood pressure.
It's like the ultimate system crash for the brain.
Exactly. Left untreated, the mortality rate is incredibly high. It is precisely why administering high-potency drugs like haloperidol, especially to agitated or nonverbal patients who can't articulate their side effects, is handled with extreme caution today.
So if you're listening to this and you're hearing about permanent facial tics, life-threatening fevers, and agonizing muscle spasms, you can completely understand why the pharmaceutical industry pushed so aggressively in the 1990s for the second generation, the atypical antipsychotics.
Drugs like risperidone and olanzapine.
Exactly. They were marketed to doctors and patients as the ultimate scientific upgrade, the clean fix that left the movement pathways alone.
That was the dominant medical narrative for nearly 20 years. The atypicals were viewed as a stripped upgrade equally effective at stopping psychosis, but supposedly free of the historical baggage of movement disorders. But what's fascinating here is how a massive independent study in 2005 completely dismantled that pristine marketing narrative.
The KT trial.
The KT trial.
Funded by the National Institute of Mental Health, meaning no pharmaceutical company was pulling the strings. They tracked over 1,400 patients in real-world clinic conditions, not highly controlled lab environments. What did they find?
Well, they pitted an older first-generation typical drug called perfenazine against several of the newer, heavily patented, vastly more expensive atypicals, and the medical community was shocked.
Because the old drug held its own, didn't it?
It did. The older typical drug performed comparably to almost all of the newer atypicals on the primary outcome measure, which was simply how long patients could tolerate staying on the medication before quitting. In several metrics, the generic older drug actually outperformed the expensive new ones.
You know, if you've ever assumed that a newer, wildly expensive medication with a slick marketing campaign is automatically a scientific upgrade over a generic pill from the 1950s, the KT trial completely shatters that assumption. The newer drugs weren't better at curing the illness.
They weren't a strict upgrade at all. The Katie trial proved that we're still just playing with that clinical soundboard. The atypicals didn't eliminate side effects, they just traded the severe movement disorders for a different, equally dangerous set of problems known as metabolic syndrome.
And we should define that, because it's not just gaining a few pounds.
No, not at all.
Metabolic syndrome from atypical antipsychotics means massive, rapid weight gain, severe insulin resistance, soaring cholesterol levels, and a hugely elevated risk of developing type 2 diabetes and cardiovascular disease.
You aren't upgrading the patient's health, you are just swapping a neurological toxicity profile for a metabolic toxicity profile. That realization renewed clinical and economic interest in typicals. Doctors realized that for some patients, the older drugs were actually the safer long-term bet.
Which brings us to the present day. Because of this tangled history of accidental cures, heavy pharmaceutical marketing, and brutal side effects, a massive pile of myths has built up around first-generation antipsychotics. We need to clear these up because it explains why these old drugs are still a cornerstone of global health today.
Yeah, there are a few major misconceptions that clinicians fight against constantly. The first misconception is the old idea that typical antipsychotics are just chemical straitjackets or heavy tranquilizers used to sedate unruly patients into compliance.
The old, outdated term major tranquilizer is definitely to blame for that. But as we established with our main breaker analogy, the actual therapeutic mechanism is precise D2 dopamine blockade in the mesolimbic pathway. It is not generalized sedation.
Right.
A patient given haloperidol can be fully awake, alert, and capable of holding a lucid conversation, while the terrifying voices in their head quietly resolve.
The sedation is merely an accidental side effect, depending on the drug's affinity for histamine receptors, not the cure itself. Misconception number 2, movement side effects, like the spasms or akathisia, only happen if a doctor accidentally administers a massive toxic overdose.
Also false. As the receptor binding affinity shows us, those extrapyramidal symptoms are entirely dose-dependent, but they happen at standard, totally normal therapeutic doses.
Exactly.
You don't have to overdose to get a dystonic reaction. It can happen hours after taking the exact dose the doctor prescribed.
Misconception 3, and this ties directly back to the Katie trial, atypicals do not cause movement issues.
The pharmaceutical marketers certainly wanted everyone to believe that.
But it's demonstrably false. Drugs like risperidone, a very common atypical, will absolutely cause Parkinsonism and movement side effects at a rate that approaches the older typical drugs if the dose is pushed high enough.
So the biochemical line between typical and atypical is just an incredibly blurry matter of degree, not a clean binary split.
Exactly. And the final misconception, which is perhaps the most difficult for families to accept these drugs, cure schizophrenia.
They don't.
They do not. They are symptom management tools. They suppress the positive symptoms, the hallucinations and delusions, but they do absolutely nothing to reverse the underlying disease process. And as we discussed with the mesocortical pathway, they are practically useless against the negative symptoms.
Like the cognitive impairment and emotional blunting.
Right, which are often the things that permanently disable a patient's ability to function in society.
But despite all of this, despite the terrifying movement disorders, the lack of a true cure, and the confusing historical labels, first-generation typical antipsychotics remain in active daily use around the world. They aren't locked away in a medical museum.
Right, and if we connect this to the bigger picture, you have to look at the staggering economic realities of global public health. Haloperidol remains one of the most widely used psychiatric drugs on Earth. It holds a permanent spot on the World Health Organization's list of essential medicines.
Why? Because we have 70 years of massive global data on how it acts.
Yes. It can be administered quickly in emergency rooms via injection, and crucially, it costs absolute pennies per dose in generic form compared to patented atypicals that can cost hundreds of dollars a month.
Wow.
In lower resource health systems globally, that generic cost is literally the deciding factor in whether a human being gets any treatment at all.
So what does this all mean? It means that typical antipsychotics are fundamentally imperfect tools. They are the blunt instrument shutting off the main power breaker to fix a single light bulb, but they are nonetheless absolutely vital to keeping millions of people tethered to reality during severe psychiatric emergencies today.
We've traced an incredible non-linear journey today.
Yeah.
From a French chemist searching for an allergy pill to a surgeon inducing artificial hibernation, all the way to unraveling the biological map of the brain's dopamine pathways.
And grappling with the sobering reality of what it means to manage severe mental illness. a daily high-stakes balancing act between relieving the horrors of psychosis and inflicting the heavy, permanent toll of movement disorders.
It is a profound testament to how messy, human, and wildly accidental the progress of medical science really is.
It really is. And I want to leave you with one final provocative thought to mull over. We talk about how the entire distinction between typical and atypical antipsychotics, a distinction that shaped decades of medical training, turned out to be more about pharmaceutical marketing and historical timing than clean, definitive science.
Yeah.
It makes you wonder, as you navigate your own healthcare, how many other rigid categories in modern medicine, things we trust implicitly as absolute scientific fact, are actually just artifacts of marketing and historical accidents.
That is a deeply important question to keep in mind the next time you look at any medical taxonomy or a new drug commercial.
Like we said at the start, sometimes you just don't get the clean, binary X-ray of a broken bone. Sometimes the labels are just historical guesses, and you just have to wade through the medical muddy waters, doing the absolute best you can with the imperfect tools you accidentally found. Thank you for joining us on this deep dive.